Paul took a deep breath to still his trembling. If I call out, there'll be servants on you in seconds, and you'll die. Servants will not pass your mother who stands guard outside that door. Depend on it. Your mother survived this test. Now it's your turn. Be honored. We seldom administer this to men children. Curiosity reduced Paul's fear to a manageable level. He heard truth in the old woman's voice, no denying it. If his mother stood guard out there, if this were truly a test, and whatever it was, he knew himself caught in it, trapped by that hand at his neck, the Gom Jabbar. He recalled the response from the Litany against fear, as his mother had taught him out of the Bene Gesserit rite. I must not fear. Fear is the mind killer. Fear is the little death that brings total obliteration. I will face my fear. I will permit it to pass over me and through me. And when it has gone past, I will turn the inner eye to see its path. Where the fear has gone, there will be nothing. Only I will remain. He felt calmness return, said, "Get on with it, old woman." And that is an excerpt from the novel Dune by Frank Herbert. The passage is called The Litany Against Fear, and it appears in the very first chapter of the original Dune novel, and it is a Bene Gesserit technique to calm oneself and suppress the natural effects of fear on the nervous system. Good afternoon and welcome to 3 Deeper Cuts Podcast, your lifestyle magazine for the practicing surgical pathologist. I'm your host, Chuck G. This podcast, which is something to think about, something to read, and something to listen to every 2 to 3 weeks. 3 Deeper Cuts is brought to you from the trenches of medicine. My guest on the show this month is CoffeeBlackMD. Coffee Black is a practicing pulmonary critical care physician in the United States. He sees the sickest patients in his community on a daily basis. He is also building a concierge lifestyle practice on the side with his friends. In this conversation, we talk about Coffee Black's journey, starting out in academic medicine and then moving into private practice, and his reasons for doing so. Coffee Black shares stories from the trenches of critical care medicine, including his harrowing experience taking care of patients during the COVID-19 pandemic. He is a healer, a health bro, and a working father. You will enjoy this conversation on 3 Deeper Cuts Podcast. Let's get into it. And we are live. Dr. Josh, thanks for coming on, man. How are you today?
I'm good. I appreciate you having me on, being interested in interviewing me, and I think it's going to be a lot of fun.
Excellent. So you and I just connected on the interwebs. I think we were we're just both working docs in different specialties. Can you tell the listeners what specialty you're in and how you chose it?
I currently practice pulmonary and critical care medicine. First became interested, I think, in the intensive care unit in medical school. Did my intern, one of your fourth year rotations for people that maybe aren't as familiar with this, that everyone does one where it's okay, you're acting more like an intern, try to sort of an audition kind of rotation type of thing. And I was working at the county hospital and had an open ICU, and we were taking care of a lot of critical care patients in there too. The ventilators, the awful infections, the medications you use either to keep blood pressures up or keep the heart beating strong. So that stuff became super fascinating to me. And I think, like most people that go into pulmonary critical care, you fall in love with the critical care stuff first. You see it as a challenge. There are things that you do that are very procedural often. It's not surgery, which is technical and it's exacting in its own different sort of skill set. But the procedures are one of those things I think a lot of people get very interested in because you're doing kind of invasive things to patients ostensibly to help them out.
It's a life or death.
These are the optimal things, or this is the safest way to do the thing that we need to do for the patient. I fell in love with that first. And when I got to residency, it was a similar thing. It was like, okay, I want to try to get as many ICU rotations as I could. When at that time, they did have some critical care fellowships that had been around for a while that popped up, but the mentors I had in residency were like, most people do this pulmonary and critical care, so why don't you start taking some pulmonary rotations as well? So I did a lot of pulmonary rotations as well and began finding the lungs to be a lot more interesting, like at that level, than I thought they were, I guess, when I was in medical school or even before that time. And it's funny because I think a lot of docs on the outside looking into pulmonary just shake their heads and they're like, it's just all inhalers, steroids, and antibiotics. And it is. But there's just a lot of nuance, like when you use them, how you use them, for how long you use them, how are you going to help the patient, and then also hopefully have them on as minimal amount of medication as is necessary at some point, and then the workups for different things. Pulmonary became one of these things too that I found a lot of interest in, especially since it's one organ, you can get dialed in and become really good on the things that organ has and commonly has problems with. And that also helps with efficiency, for instance. But also then when you do have like weird cases or cases where you have to do a lot of extra workup or investigation, they aren't like taking like a ton of your time because most of your time is being very efficient. But I guess back to the question, so then is putting those two things together in residency were what really got me interested in, okay, I'm going to apply for this. At the time, I was very interested in being a physician scientist. Prior to residency, I'd spent a year in a lab we were doing research on mice, making them hypoxic or messing with their calories. And these were pregnant mice, and we were looking to see what the differences were in certain gene frequencies that were related to stress. My mentor at the time, I might get too off.
No, this is very interesting.
Okay.
I'm taking notes so I can follow up.
Okay. So the lab guy, the mentor at the time, was really, he'd read a paper, and I believe this was from the Dutch in World War II. I think they were totally blockaded by the Nazis at one point. Like nothing was getting in or out.
Okay.
And part of this sort of like the analysis was all the babies born to mothers pregnant during this time when there was a lot of scarcity have higher rates of like diabetes and heart disease and cancer. And so what's that all about? Yes. And then the late 2000s, I think, was when we're really starting to start to look into the epigenetic stuff. It's okay, so how is the epigenetic stuff apply to a genome where like these genes are there, they should be working. It's not like it's big mutation or like a huge chromosomal abnormality. So what was the difference, right? And so the theory is that these epigenetic factors are like dimmer switches.
Okay.
So they control like how much a gene will be expressed, or I suppose not expressed, depending on the situation. And you know how those things get turned on and off, which I'm sure you remember is super complicated, and not even what we learned in medical school is not even at the level of what they understand now as far as like how things get turned on and off. But I do the analogy of a dimmer switch. So if you're having a lot of stress, a lot of DNA methylation at this point, you may actually be turning down certain genes or turning them up. So like the light's on, the gene is working, it's not a problem, but access to it is just not as, or I suppose the opposite is true. Maybe something demethylates and you have more access to certain genes. Regardless, I'd gotten interested in just doing basic science research. When it came time to apply for fellowships, I wanted to do some more basic science stuff. I wanted to be a physician researcher, wanted to go to somewhere where I was going to get like a year and a half of protected lab time. And that's what I found. That's where I ended up, was a very academic fellowship. I did a lot of that. I gave mice pneumonia. Pseudomonas pneumonia. They were
Nice.
knockout mice.
Okay.
And we were trying to ascertain certain inflammatory pathways and to see if we knocked out this particular intermediary, do they survive or do they die, sort of thing. And so, yeah, I guess that's how I got to fellowship from
Very
med
cool.
school, kind of my interest, and then on the way to looking for fellowship, for sure.
Okay. So I wanted to follow up with that. So that's how you started out, and
Mm-hmm.
and now you're an early to mid career physician. You're also a family man. What are you most optimistic about or excited about in medicine, like in your current practice?
And we've talked about some of this stuff, and I think in some spaces on the Twitter, the X, and it's what am I excited about, and that's a problem because what am I excited about in the ICU and corporate medicine isn't much. So I'm not trying to be like a black pill doomer here
No, that's
because I don't
fine.
think it has to be. I don't think it has to be this way forever. But like the
Right.
way it's currently being run for a number of reasons, some of them are probably cynical, and some of them are like just the law of good intentions, like just spiraling out in ways that no one could have predicted, at least as it applies to quote Obamacare, the what's that, the accountability and what you know what I'm talking
Yeah.
about anyway. So
Yeah.
I don't want to be like overly
No,
partisan using the using the
no, that's
quote
fine.
like
No, this
Obamacare.
is the place. This is the place to talk about that stuff, the good and the bad.
Yeah. Okay. And these factors have led to basically setups of working docs. I won't be the first doc that's told you this, and I don't know how far pathology you're able to keep some of this at arm's length. I got no clue, but a lot of us are just, we aren't being really treated like clinicians, professionals, like it used to be. It's, oh, we're cogs in this wheel, and you have to see this many patients. You have to be here for this many hours. You have to do this much documentation. You have to, like, these medical records have put all these, say, results online. They're straight to the patient. If you're not like giving them updates right away, people are freaking out, and it's just constantly, just you can't keep any of it like at arm's length. It's just constantly in your face. Like most people, they work a regular job, right?
Mhm.
I don't know, let's say you're a guy and you code at wherever, some tech company. Maybe that's a bad example because I think those guys get overworked too. But
They probably
yeah,
have it
maybe
worse,
the
honestly.
mechanic.
Like,
Yeah, yeah. So let's say you're a mechanic, right? So like you're working at the Ford dealership. You show up in the morning. You take care of trucks all day long. When it's time, it's done. You go home. You're not like working on trucks at home,
right.
right? You're not like putting new brake pads in someone's car at home, right? And so you're able to keep a lot of that at arm's length. And I think that there's also this very, it's a human thing. We're just very self-centered. I don't mean it in like necessarily a awful way, but just like we just are. And we don't have the sense that there's 5,000 other patients that doctor is dealing with, not just me and my issue, right?
Correct.
And for any of us, though, like when that issue is your issue, that's like pretty freaking important. This is important to me. I'm not breathing very well right now. What the fuck are you doing? So I can get that too. So you put these things together, the corporate side of things, and like how they're trying to get us to do so much with really less, but also, and I don't want to get into it. Oh, poor us doctors, we're not getting paid enough part of things, but the pay that they offer us, which is good compared to most of America,
Right.
I'm not starving, right? But it's not commensurate with this, especially with the
Correct.
responsibility that
Yes.
they want us to take on.
Yes.
Because all docs are taking on a ton of responsibility. It's like you as a pathologist, you're saying this is cancer, no cancer, right?
Yep.
That's a big deal, right? It's a huge deal because if it's cancer, we're going down a pathway where we're after this stuff. We're this chemotherapy, these immunologics, maybe radiation. It's a big deal, and
Hmm.
there's also possible complications that come with that. So if you say it's cancer and it's not, we give people poison. It's okay. Everyone's really fucked it up.
Yes.
And so I don't think people understand that level of responsibility because we make calls. Most people don't make these kinds of calls. It's if I've got a patient, bring it back to my specialty. I'm in the ICU. It's middle of the night. I got a patient who's got a heart attack and a GI bleed at the same time. What do I
Wow.
do, bro? I mean, I'll tell you in general, it's my opinion that heart trumps the gut, and I have just poured blood into patients so that way they can get their heart attack sorted out.
Yeah.
And it's totally nuanced too, because let's say you got a patient who's 85. And I don't want to make it sound like I don't try to save every 85-year-old that comes into my ICU. I totally do. I'm not here to, I'm not angel of death. I got into this job to save people, to help people. But if that guy's having a heart attack and a GI bleed, and he's also got like a bad cardiomyopathy, aortic stenosis that's severe, and peripheral vascular disease, he's already lost a couple of toes, we're probably not going to take that guy to the cath lab. And that's a decision that I have to make. That's a decision that cardiologist has to make. And then we've got like probably a GI doc involved in this case who's got to come in and say, okay, I'm about to put a scope in an 85-year-old who could crump the second we give him a little bit of sedation or I try to intubate him. I have had people try to die right in front of me when I intubate them, Chuck.
Wow.
This is like tough stuff. And again, how much is that worth? I don't know, man, but it's more than they're paying me. I really feel like it is.
We could actually just dumb this down and have it be performed by somebody who never went to medical school or did a residency and has no accountability. We could just do that, right?
I think that would be a recipe for huge disaster.
So the over-reliance on mid-levels, what is your take on that, and how does that affect your practice?
So I work closely with mid-levels, and I like them as an extender, okay? So when I'm in the ICU, my mid-levels will they're basically like my intern. They take all the pages.
Okay.
So everything's getting filtered through them. So that allows me to be able to work undisturbed. Stuff still comes through occasionally. The way Epic is set up these days with their haiku, it's like people think it's a chat app, but it's not. But most first pages go through them. If it's simple stuff, they can sort through some. They might be like, oh, this patient's glucose is running a bit high. Can we move from the low to the moderate sliding scale? Totally fine, right? Like me, I trust them.
Yeah.
Because the people I work with, they know what they don't know, and that's very important.
Yes.
They know what they do not know. So they know when it's time to bug me, right?
Yep.
Hey, this patient's got atrial fibrillation and cardiologist had him on like amiodarone or something, but it's still going fast. Like in that situation, like, what do you want to do? Talking to me. Mm-hmm. Which is always funny because, well, what did cardiology want to do? I thought they were involved in this case. But I go come up with something, right? Yeah. That's some additional metoprolol, maybe diltiazem drip, maybe I got to give someone, just there's options, right? Things that we can try to do. And so, yeah, just where were we going with this? I'm trying to remember.
Well,
it was,
so I never thought
on mid-levels. I'm sorry.
Yeah, so on mid-levels, and I'll just share with you on the back end.
Yeah.
I come from the outpatient world. That's where I started my career. And I, too, was working closely with mid-levels, very good ones. And there was a mutual respect. And they really knew their limits, and there was a humility there. I noticed when I went civilian and training at a large academic institution, I didn't quite see that as much. And I saw that at a big corporate hospital where I trained, there was a lot of reliance on mid-levels, and the documentation was confusing. And a lot of time it was difficult to decipher what was going on, and you just wondered, has anyone even performed a history and physical exam, or is this just a bunch of copy-forward lab results and mixing up the subjective and the assessment? It's all over the place. I think that was just my take on it. And I'm not trying to disrespect their profession because they're integral to Western medicine, but I know that the incentives are aligned, where I'd like your input on this too. Like the incentives from corporate medicine are aligned to push their scope as much as possible. I don't know. What have you seen in the trenches?
Oh, I would say 100% overall. They're always asking if we can do this with mid-levels first, right? So for instance, I don't want to make this too job specific. Let me just put it this way. So there is a situation in the hospital system that I work with where they'd like some additional coverage in an area at night. And we've said we don't have enough doctors for that and we need more doctors. And they said that will cost us too much. And we do this with mid-levels.
Okay.
And when we went and we sat and we thought about it, we're like, okay, possibly. But you have to recruit the right mid-levels, right? So someone who's had experience in an ICU, for instance, who has worked, maybe even worked by themselves some, right? Okay. And then we're going to have to train them for a year to do things our way. with our current mid-levels and with our current docs, and just here's how we do things. Like if we're going to be managing things together, but at a distance. And they didn't like the idea that it was going to be like 2 years out trying to do it that way, probably. When we said, look, if you hire docs, anyone can come from fellowship and do this work day one. So that's the right way to do it. And a lot of the other services were wanting, they said, we want docs out here. If you want us like building these things. So it'd be cardiology, interventional radiology, and gastroenterology are saying, look, we want docs here at night if you want us building up this stuff that you want us to do, because they support everything. And when it's just so short-sighted that you've got these administration types who just can't see, okay, yeah, right now, or maybe we will never actually, with the amount of documentation we can put together in a hospital, say, be able to prove right now we can pay for ourselves. But all these services that bill lots of money to this institution want us there as backup. You can't see how like you're stepping over dimes to pick up pennies.
Yep.
And it's just nuts. And administrators hate to hear from us, especially in critical care and in pulmonary, that the downstream revenue is completely dependent on us. On the pulmonary side, like all the lung cancer stuff, like until we biopsy it, no one does dick. Like, what is it? I don't know. Our surgeons will not see these patients first. They're busy. They're like, you send these patients to pulmonary, and if they think they should come to us after they've sorted it all out, we'll take it out, right? We have a tumor board. We talk about things, but I'm just saying, but in general, that's the way our culture is around here. Okay. And so it's, look, your ORs and your radiation oncologists, your radiation machine and your infusion centers dripping the chemo, they're making $0 until I biopsy it. So we need anesthesia support to help with biopsying. That was one of the things we've been fighting for years.
Okay.
Just nuts. Just dedicated anesthesia, because when you're going in and you're biopsying stuff in the lungs, these patients, look, people have been doing this stuff with conscious sedation forever. I think that running, and there's people that do run conscious sedation for these patients or have for a long time. And I'm not here to tell you that's not considered a standard of care. It's a normal thing people will do. I just don't think it's safe.
Okay.
I think it is. I think that you're trying to do the job of two types of professionals at the same time. And if you're new to just get a quick lavage, you're just giving a little bit of stuff, knocking them out a little bit and getting in there 5 minutes, quick lavage coming out, that's probably fine. But if you're spending like an hour and a half in a biopsy case, you need someone who's actually really paying attention to the vital signs, how deep sedation is, what the airways, what's going on with the airways. I think all these patients need anesthesia involved. And I've got a strong opinion about this after just tangent here just a bit. I had a case when I was newly attending. This was a guy, he was a young guy. Well, I guess I'd say he wasn't like old. He was like in his mid 40s, right? Firefighter, right? Wife, kids, good dude. You know what I mean? Like, stand up, like good citizen, right? He had this big lymph node. And I was like, shit. I said, I know exactly what that lymph node is. And I can just put a Wang needle right in there. Have you ever seen a Wang needle, Chuck?
No.
They're big. Okay. They're obnoxiously big. I only had them under conscious sedation. I got onto the wall and I popped through with the Wang needle because I knew exactly what this thing was. And then he started coughing. My needle's buried in this guy's chest, Chuck. Wow. And then he went tachycardic up to 170. And I was like, oh shit. And my career like flashed in front of my whole eyes. I just torn open this guy's pulmonary artery, like this firefighter. He's got kids in grade school, lovely wife type of thing. You know what I'm saying? It was like, and so after that, like he did fine. Heart rate settled down. There was no problems. Got a CAT scan, talked to him about it. Actually, that sample actually showed some fungus, which it was good. Okay. I guess in some ways I was able to get some answers. And this guy had this weird fungal stuff. And it also got into his sinuses. And he was having awful asthma because of it. And once they cleaned out his sinuses, his asthma went away. And I've not seen this guy in years.
Wow.
Interesting case. But regardless, back to where I was saying is after that, I was like, nope, no biopsies unless anesthesia has them knocked out, period. End of story.
That's all I've seen with those biopsy cases, whether it's EBUS or whatever advanced technology, the VIRAN. They're always coming out with something new. But every time I've been there, fellowship, residency, and in practice, there's always an anesthesiologist there. I know in some cases they use a CRNA, and they usually just ask for a quick adequacy assessment. I can't imagine doing that without anesthesia professional there.
Exactly. That's the only way we do it now. Our anesthesiologists are there for the intubation, and then they make sure the case gets kicked off. And the CRNA just runs just to make sure that the sedation of the patient stays stated. And but it's been trying to get time for that. And bronchoscopies do not, I mean, like the hospital gets the bill for the endo time, they get the bill for the anesthesia time, but the bronchoscopy portion of it is wimpy.
Okay.
So it's funny. There's no big incentive because hernia, gallbladder, anything bigger than that, colectomy, those are like much more lucrative. It's an awful way to think about it, isn't it?
Yeah.
But the hospital makes more money by supporting that part of the OR, and just back to bring us circle back where we were. And so that's where we're talking about, like, you don't see it because you don't see that, you're not paying attention to the downstream effects. They don't care till the patient gets to the OR, thoracic surgeon. They don't care till the patient gets onto the bed in radiation oncology. They don't care till the patient sits down in that infusion center and gets the expensive chemotherapy, right?
Yeah.
But if you put all that stuff together, all that money they make downstream of us, they would want us to have a guy running that room every day.
I see. It's still, this is where these incentives get so distorted when the reimbursement doesn't match the medical complexity and severity of the issue. Like you said, some of these cases can go an hour and a half, in some cases more, if there's a difficulty getting to it, and then you find out it's malignant, then you want to do some extra staging. And this is actually the first I've heard of not having anesthesia present.
Then I'm glad to hear that. I think that's becoming the standard everywhere for these kinds of cases. I just wanted to be careful because there may be someone that eventually hears this and they're like, oh, well, I run conscious sedation. And I just wanted to just be like, hey, look, I'm not trying to throw anyone on a bus or motherfucker anybody. It's just,
yeah. No, it is what it is. But that's the purpose of this podcast, because it's like medicine has become and we've touched on this in spaces, is once you silo healthcare into like these MBA-driven corporate healthcare systems, you can no longer question the status quo. And now you're like punished and everyone's afraid of getting fired. It's just like, no, it's okay that some things people disagree on. We're supposed to be able to talk about this without somebody flying off the handle getting fired. It's just,
right.
This is it's a learned profession. People are,
right.
You have experiences in practice that led you to have this opinion, which I think is very valid, and I think a lot of rational practicing pulmonologists would totally agree with you. I really don't see why this particular subject is controversial, and I also don't think that you and I are fairly careful with what we put out on the internet. But a lot of that is to protect our patients, because my name is and your name is all over documentation. We're still human beings. We should have the freedom to express ourselves and, in a relatively professional manner, just discuss things. But
right, I totally agree, 100%.
So it's just mainly to protect patients, because Google search results match up with cancer reports, and I would never want anything to. They should have the utmost trust in their report, their proceduralist, and what have you. So, anyways,
100%.
So moving along, so you're mid-career, and it sounds like you're at a busy practice, and I know you're in some of the northern states. So what was your biggest influence so far in medicine? Like, just as a pulmonologist, what's been your biggest professional influence? Either person or situation.
Oh, man. So I worked with a number of really good attendings over the years, like in training for sure. And guys I would just love to name, to stay a little anonymous. But like the guy that was the director of pulmonary and critical care in my residency program was the best bedside clinician I've ever worked with. Brilliant man, trained at some of the best places. You're thinking like top 10 places. Okay. Yeah. Did a lot of research prior to coming to where I did my residency. Also just really fucking cared about patients. Just nice. A good dude.
Yeah.
And he just was one of the best diagnostic guys I'd ever worked with, just at the bedside, just like figuring things out. Here's how you work through this stuff, Josh. I was like, oh, okay, there's a method, right? There's efficiency, and there's things that you can ignore, and there's things you got to pay attention to. Just interesting. And so I think he's the number one reason I got into the fellowship I did. I think he
Okay.
called and was like, hey, I'm vouching for this kid.
Nice.
And that means a lot to me. He's never told me that. He was one of these guys that wrote me an amazing letter
Mm-hmm.
and made sure that I got to see my copy.
Awesome.
So you can see what some of these people like really think about you when like they write stuff. So he was a huge influence. Fellowship was a different sort of beast at the big academic center. And I think you also said you did some training at a big academic place at one point in time. And it's a snake pit, man. It's hard to find people that like are going to care about you, who don't see you like as like at least a little bit of their competition somehow. It's just wild.
Yep.
At least maybe that wasn't your experience. Maybe you had a different academic experience, but like where I was, it was like, yeah, this is not okay. The guy to research with, I hoped would be my mentor, and he had a ton of personal problems going on. He had an R01 award, so he had some money, which was good, but he was like absent in the lab and wasn't applying for new grants. And we had a Chinese postdoc working with us at fellowship.
Okay.
Good dude, super smart. His English was actually pretty good, but the accent was thick sometimes. But he was really patient with me, really showed me how to do stuff in the lab. And I remember him at one point towards the end of my 18 months in the lab being like, hey, Josh, like, what the fuck's going on with the grant? And I was like, I don't know. As far as I know, he's not written another grant. So I don't know if there's any money to pay your salary next year, just bros being bros.
Mm-hmm.
And he ended up leaving the lab. So then it's just like me in the lab. And so this guy that I was hoping would be my mentor just never was, which really sucked. I wrote a 30-page paper on the data that we'd come up with and the whole bit, introduction, materials, your methods, your results,
Sure.
discussion, all the references, 30-page paper, ready. I mean, it wasn't ready to be like go prime time yet because you have to go through edits, take a look at it, but the paper was done. You know what I'm saying?
Yep.
I left it there with him. He never fucking called.
Oh man.
It was just, dude, like, we can finish this up. Like, I know I'll be busy as a new attending, but like, we can get this finished up. Let's do it. But I can't personally carry this over the line, right? He's the guy. He's, the last author on this paper, right?
Yeah.
So it's for him to submit. Never did. So, and I don't know, man. And I don't know if they all got salty because I left. Because they all thought maybe I was going to stay.
Oh,
But there was no discussion about like how it was going to work because I had no money. So are you aware of what are called the K Awards?
yes. Yeah. That's like a crucial part. That's like the big.
It's like the
step.
first award you get as a young physician scientist.
Yep.
Okay. So if you go to places like maybe like Penn, Hopkins, San Francisco, UCSF, like those guys might be able to come out of fellowship into a KO1 as long as there's the right mentor they're working with them. But like we weren't big enough for that sort of kind of consideration. Does that make any sense?
Okay.
And so it was okay. So like you could maybe apply for your K in 2 or 3 years type of thing. Was build your repertoire here a bit more kind of thing. But it was like, but I've got no money. Right. So like, how do I do that? Is there like an internal grant? Can I get $5,000 to just get some reagents, get some things going? Like whose lab can I be in? Like I need probably maybe not 6 feet of lab. I mean, 3 to 4 feet of like just bench space where that's yours. And it would need some space in a deep freeze. No one came up to me. No one had thought about any of this. No one tried to figure it out. And then, I went looking for jobs and we can get to that part later. But when they found out I wasn't going to stay there, here's what we got an offer, right? And it was like basically they said, okay, you'll have 80% clinical, 20% dedicated research time. Okay. They said you will get $120,000 a year. Okay. This is in like 2013. So you know what doctor salaries were back then.
Yeah.
$120,000 a year to cover the consult service during the day and the ICU on the weekends. And I was like, you guys are fucking out of your goddamn minds.
Interesting.
Excuse my language.
No, that's
Like you know, I mean,
abuse.
here's the
That's
thing.
like
That
financially abusive.
I'm just saying. Here's the thing, though. You could see a situation. Hey, listen, it's 120. You got to work like this, but you're 20% off. Your 20% research time. Here's how we're going to get you set up. You see what I'm saying?
Yeah, yeah.
Like, you're going to work in Dr. Smith's lab, and he's got room in his deep freeze, and here's $10,000. You get some reagents, start getting stuff going. You know, we want to see it. You know what I'm saying, like, you're like,
Yeah.
oh, okay, so I got people that got my back here now. They
Right,
want me
right.
to be, and then I'd be like, okay, maybe you gut it out. You're still a young doc at that point. Maybe you gut it out for 2 or 3 years, see how it goes. Maybe you apply for your K, maybe you get it, maybe you don't. Maybe then you make some reevaluate some things. But it was, and so that's why I didn't stay in academics, even though that's what I wanted to do.
Wow.
And
But it's
while I was in, go on, sorry, I walked all over you.
no, that's I was never interested in staying in academia, but my colleagues that I trained with were, and it is remarkable how similar your story is to some very bright young physicians, published physicians, a lot smarter than I was or am, and they had similar things. There's an element of chance there, where if you just get stuck with people that just they're just not good people. They don't really want to see you succeed. Then you're just gonna leave. And I mean, if I were you, I would have done the exact same thing. And the joke's on them. You're in a beautiful part of the country, just enjoying your kids and your family, and building a little something on the side on the long term. So let's talk a little bit about that, if you don't mind.
Sure. Oh, go ahead, please.
We touched on this a little bit in the DMs, and I just find it really interesting. I grew up in a small town in Nebraska, or a college town in Nebraska, and by way of my profession, I don't have to be in a big city, but so I grew up in a kind of a small to medium-sized town in Nebraska, and I didn't foresee myself winding up in a big city, but there were some options to be in a smaller town. But just professionally, pathology is one of those things where you got to see, just like anything in medicine, you want to see a lot of really complicated stuff earlier in your career, ideally. And
Right.
it's just different than clinical medicine. You know what I mean? You got to kind of be at a referral center as a pathologist to really, to stay good. And not only that, to be around people that are smarter than
Right.
you and have seen more stuff than you, especially earlier
Right.
in your career. Because outside of academics, like, you want to be around these people, right? They're your
Mm-hmm.
teachers now. Otherwise, you just atrophy. There's no one to calibrate you. So that's why I chose to be in a big city. As we've talked on in spaces and messaging, is that the, there is a downside to being in big cities, especially during times of civil unrest and political uncertainty. And in my vacation time, I always am drawn to the West and the West Texas, the mountains, and
Oh,
the
yes.
ocean. I got some family in San Diego. So yeah, I think somehow the conversation led to this side thing that you're working on, which is a retreat deep in the mountains. So could you tell us a little bit more about that?
That's really the end goal. So, man, story getting there. We, I, we walk it back a little bit to COVID.
Okay.
So, being an ICU doctor during the COVID pandemic at its worst times was very stressful. At the height of Delta, I there was probably days in our ICU where we had 3 or 4 people dying a day.
Wow.
And that was after you'd spent like sometimes 5 or 6 weeks trying to keep them alive. And you got to remember at this time too, like how tense it freaking was, especially like ivermectin. It was like this wave of this next wave of Delta, and half the country was going nuts about it again. And then we also had the vaccines, and when it was just like, and they weren't letting anyone come into the hospitals. It was fucking
Yeah.
tense, bro. And I was having to talk to these families like on the phone or via iPads, and everyone's pissed.
Wow.
Almost everyone is pissed. And once you're hearing stuff like ventilators kill people, it was just like, it's like, oh my God. And it was a tough time. And so I knew I was burnt out. I knew that I was feeling really down. I don't like to throw around like PTSD because there's really people that have these awful traumas, but it's something along those lines, right? It was just like this bad time that kind of smoldered on. And so I was just like, man, what can I was like, I didn't have any friends. My marriage at that time was not fantastic. And I was like, I need to find some friends. And I also was starting to look into just like, what are some of these people doing with PTSD? And at this time, I was on X. I was pretty new
Okay.
at the time, and just went down this rabbit hole of psilocybin, magic mushrooms. And how it was being used in PTSD
Right.
combat vets, and how it seemed to work really well with men. I was like, oh. And I ran into a guy at work. He's a nurse who knew about this stuff. And we just got together and started talking about this stuff. And he knew a guy who had opened ketamine clinics as part of he was an administrative guy, non-clinical psychologist, who was very interested in kind of what we're talking about. Hey, maybe we can figure out a way to help men's mental health. And so the idea is that we get guys, I guess, was to help out guys. They started with just men, like just feel better, look better, be better. And so part of that was like we can optimize things like hormones. If guys are low on testosterone, they'll feel better. They'll act more like men. They'll be better people. On top of that is like we can help guys lose weight. We want to. Also part of this was going to be maybe have a gym someday, which I won't get into that just yet.
Sure.
But we'd be like, okay, we can help guys like with training, with weight loss. You've got a guy who says, hey, I want to run a 3-hour marathon. We'll be like, hey, we know a guy. He'll train you. Some guy comes in and says, hey, I want to be able to deadlift 700 pounds. It's not something that's totally ridiculous, but also something you'd have to really train up to be like, hey, we know a guy. We got you. Like, we're going to help you do these sorts of things. I think that's important for men to have these little things that they like do and conquer. Because we don't sail off the sea anymore. It's okay. What can we try to conquer? Conquer things like within ourselves, make ourselves better, stronger. And then there was also going to be like this psychological component. Talk to guys about the things that, that they want to talk about. Because current psychotherapy, I'm sorry, some people try to say it's not like really femi or gynocentric, but it really is.
Yeah.
And I know some guys, because I know this from Twitter, like, oh, some guys do fine with it. Okay, fine. Okay, some guys. But most guys don't. It's ineffective, right? And so that's where we came to, okay, psilocybin therapy, interesting idea. And what about having this ranch, like the end goal dream? Got this ranch, there'd be like a bunkhouse. And in that bunkhouse, you'd have space for, just think about a bunkhouse, let's maybe space for 10 guys. And if you want to come because shit's just wild in your life for a period of time, you want to come and just hang out, work on the ranch, work out in the gym, and just chill, figure your shit out. We want to have space for that. And it'd be one of those things where it's okay, it's not the thing we'd advertise as a mouth. Like, you just if you're a dude and you're a good dude or other good dudes, you just need to like a place where they can just like, I don't know, maybe they just got divorced or something, right? Just don't know where they're going to go, don't know what they're going to do. They're just like all mixed up. They're just like, to just come here to the ranch.
This is fucking awesome, dude. Like I support this like 1,000%. I want to go. Honestly, I need something like this right now. I would pay for this. I'm looking to buy a casita in West Texas for this very reason, just to get away from it all. But I love the concept, man. So you got together with these fellow adjacent professionals, and so how's the need in your area? Like how far away from the nearest big city?
I would say we've got a metro of a decent size here. And I think there's a lot of pull from adjacent areas, which we might see as well. So I think we've got, basically, we're the only people trying to do what we're trying to do right now where I live.
Nice.
It could be really cool. So to this point, just funny. Like, you just have to move forward in this stuff sometimes, Chuck. I think too many people like sit back and wait for it to be perfect. It just never will be, right?
Right.
And so at some point, you just got to move. So we actually don't have a physical clinic location yet, but we've got some clinic space in a friend's clinic, an ally, um, so we can see people there. And he's not asking for anything in return other than we do some content with him, which he'll
Okay.
use for his own stuff. He wants to sell content. But the cool thing is, he said any content we make, it's half yours. You can use it yourself too. So, and he's got a pretty good setup for YouTube and TikTok. He does a lot of video stuff.
Okay.
And he's got a good number of followers at this point. And so he's a little professional. And so I said, that's a good idea because we can also use that stuff. Like part of the medications and things that we're going to be prescribing are, and people don't need to be afraid of injecting things. They just need to know how and where to do it. It's no big deal. Right. You know what I'm saying?
Yep.
And so I've talked to this guy, said, let's also do like an injection episode where you just teach people like where. He said, that's perfect. I love it. He'll sell that content at some point, but we've also got rights to it, so we'll just give that to our patients. Like, here's how you inject. Here's how you inject testosterone. Here's how you inject terzepatide. Here's how you inject vitamins. Here's how you inject BPC 157. And so then it's all just like there. That's kind of a cool idea.
Yeah, absolutely.
And so I'm sorry, I just walked all over you. But I was going to say, as far as the business goes, like we've got our first batch of meds paid for, and we've got a few $1,000s in the bank. Yes. So our next step right now, since this is just get a real website. That's the next step.
Nice. I love the concept, and I actually wish more people were talking about this type of thing. And I think this is an unmet need. I've seen it with people that I was in the military with. My corpsman texts me like every couple months somebody else killed themselves. The modern world is a bit isolating, which is paradoxical because everyone's so connected. That's why one of this podcast is building a writing habit as a cure for burnout. So I actually agree with you. I think that therapy is a finite thing. I was in therapy for a year. After a certain point of time, you just got to do the work. Like, you got to fix issues in your life. Your therapist is not going to do that for you. If anything, it becomes like this victim role that you're playing. It's just like, so what's the end game? You're just going to go see this person and talk to them forever? Mm-hmm. Is that right? Like, how emasculating is that? I think the one caveat would be if you're in the profession. I wouldn't trust a psychiatrist unless they too themselves were also in therapy, because they're dealing with crazy people all day long. You would need some kind of professional guidance or whatever. But outside of that setting, there has to be an end game. And a lot of, like you said, this is psycho-cybernetics. Men are goal-striving individuals. We are hunters. Mm-hmm. And once you take that away from us, just like working in a bureaucracy. I've never met somebody outside the autism spectrum who is legitimately happy in a bureaucracy that's going nowhere. Like just a dead-end government job. It's a ticket for most men, not all, but for most men, that's a ticket to depression.
Yeah, and that's bouncing off of that. One of the things that we thought would be really cool is if we actually do very well with all of this, is to actually start what I've termed a local VC kind of project, where you bring in dudes who've got business ideas, guys who don't want to work in the fucking cubicle any longer. Got business ideas, but they got no money. And if we've got enough where we can get them started, then they just pay us back, and then they have fucking business.
Nice.
I think, dude, like, guys are dying in the cubicles, bro. They're dying there. They all need to be like, since we all can't go off on adventures and not everyone can be in the military right now. That's a cool thing, depending on who some of the politicians are and what they're doing with you. But I'm just saying like in an adventure sense. So what should these guys be doing? Well, they should be trying to open businesses.
Yes.
All of them, and then we can all just do business with each other. Yes. Instead of like, especially like these big corporations and stuff. Just like, I would rather, because we've made so many relationships now, just like in our community with like just other dudes who just want to go out and have their own business. One of our pharmacies is like, he's a bro. Like, we want to do business with him, and he wants to do business with us. Like, we don't want to
Awesome.
go to these big pharmacies, like big national chains.
Right.
He's compounding stuff. He's like, anything we want, he'll make for us. It's so cool. But you know what I'm saying? But you got to foster these relationships.
Yes.
And we gotta put your money where your mouth is. Do you want to help out like regular dudes, or not? And so
You're slowly dying. If you're not building something, just if you are an XY chromosome, there's just something in there where you are happiest when you're building something. Exceptions to the rule, but this is my first job in this specialty, and when I was hunting around, I wanted to work in a state that still protected physician-owned private practices. Texas and a handful of other states are very physician-friendly for now.
yes,
We still have threats, overseas conglomerates wanting to gobble up little rural practices here and there. It's definitely happening. I don't know how long that wave will last. Pathologists tend to be very well organized, and we're doing the best we can to fight it. But yeah, so the potential to buy in as a partner to my group is something that I look forward to. And then building this podcast one day as a business is something that I look forward to. That's why I wake up in the morning. This podcast is hopefully our conversation here and hearing your story of how you, or essentially, like, not essentially, you were in a traumatic job for 2 years of pandemic. Constant work and no rest, and now you want to pay it forward and build a business that helps other working dudes, not just in medicine.
Yep.
That's what I want more of on this podcast. I mean, that is the theme of this podcast, is helping the doctor 5 years behind us, the young professional 5 years behind us, and building something positive, that our kids can look forward to it. So yeah, I would love to. I see your timeline. I read some of your stuff, and some of it's pretty funny. Some of it's pretty funny, actually, like the fucking anesthesiologist, the prima donna anesthesiologist, whatever, trying to explain to you is, oh, by the way, make sure the patient's awake when you extudate. Like, fuck you.
Right, exactly.
Fuck out of here with that weak shit. Come on, man. Like, will you really talk to people like that? This is an estrogenic way of speaking to somebody. That condescending, passive-aggressive, cunty way of speaking to somebody. That is the mission of this podcast, is also to fight that culture that exists in medicine. There will be none of that here. I know exactly.
Many motherfuckers right now.
Dude, actually,
so many motherfuckers.
This was one thing that I was alluding to earlier. So we were talking about being pseudo-anonymous, partially doxxed. Most people in my industry, I'm not a big deal, but most people that know me from residency and fellowship, they can piece it together. They know exactly who I am and where I work. But I remember, so we definitely have some very malignant personalities in academic pathology, just as anywhere else in medicine. And during my fellowship, I was on like this committee, like this practice management committee for our whatever professional organization. And so I was on this committee because I wanted to learn more about the business of pathology. And one of the topics of this webinar, put together by some very senior pathologists and business people in our country, was about how to navigate toxic personalities, both in private practice and in academia. And all of these things that they're hitting on, I'm just like, oh, wow, I work for a lady that behaves exactly like that. Gaslighting, very hot and cold, emotional, adult tantrums, screaming at the staff, screaming at other physicians. Like, this lady was out of control.
Oh, my God.
And so I was still working there, and I was writing under my own name, on my other account, Chirag and Gangahar. That's what I use just for pathology images. So I wrote a thread to the trainee 5 years behind me, how to navigate toxic personalities in medicine. And I didn't name any names, and I didn't name any institutions. And I even bounced it off of a few people in the industry before I posted it. The HR lady, or the GME lady from our department, I guess she has nothing better to do than just scroll Twitter and look for problems. So she saw this, and she saw it was attached. And my face is there, and I'm reading this, and she like freaked out, and she called the program director, and then I get called into her office. This is the last day of my fellowship, and this lady tried to maybe she thought she was intimidating me and tried to scare me that if I continue to write stuff like that, I'll get fired. And she asked me if I was talking about her. And I didn't say this at
Oh
the
my
time.
God.
I didn't say this at the time because I wanted to graduate the fellowship and get my certificate.
Right.
But
Yeah.
in my head, I was thinking, yes, because everyone, every time, at every moment in time, is talking and thinking about you. You're just that important, aren't you?
Right.
So I tucked it away. For the sake of my wife and kid, I deleted the thing, and I just I went underground I just didn't say anything. And I created this account, Chuck G. This mentality does exist in in medicine, particularly in academia, where you just have just weird narcissistic people and that just treat people like you would never treat in real life. Like you would never.
Oh, for sure.
Yeah, it's just like when you're just dealing with regular working people, there's a way of conducting yourself that I think a lot of these elite academics, they're so used to people kowtowing before them that they don't know anything different, and they get away with it for so long because they're in a position where they can't be fired, or I don't know what it is, but in any case, I think that's something that I think it's easily dealt with by just not reacting. I wish I could have talked to myself at the time, is that you just don't react, and you just don't you just don't say anything, and you just take note. Don't get emotional about it. Just take note, and but pay it forward. Warn the people behind you that this is the way it is. There's nothing you can do about it. And you get over it. But in the real world, don't you ever talk to people that way. But so anyways, man, I want to actually end this on a positive note, which is your future project.
Yeah.
And I totally,
Yes.
I'm humbled that you felt comfortable talking about that on this podcast. And in future, as it develops and, in the months and years down the road, I would love to follow up with you.
Oh, yeah, for sure.
Yeah. And I appreciate you coming on the podcast.
Yeah, this was a lot of fun. I would definitely do it again for sure.
Enjoyed that fun conversation with CoffeeBlackMD, aka Josh. To connect with Josh, you can find him at CoffeeBlackMD on the X platform. Attend some of his spaces on nutritional supplement optimization, hormone therapy optimization, and just some updates on his practice. If you like this episode, subscribe to 3deepercuts.substack.com, where you can listen to all the backed episodes of the podcast. You can also find us on Spotify and Apple Podcasts. For downloads to augment your foray into medicine, check out chuckgmd.gumroad.com, as well as chuckgmd.substack.com. And for raw, rough drafts, poems, and a preview of some fiction work that I'm putting out next year, you can check out rawcuts.substack.com.